Yes, Pramila.
Good evening, everyone. It indeed is a pleasure to be a part of IMA and do this program. And as you are all aware, we are doing this in association with National Safe Motherhood Day, and to deliver good care to our mothers and have a safe motherhood. I think it is very important that we learn the aspect of giving the care with respect. And who else can enlighten us regarding this respectful maternity care rather than our own Geeta Madam, our President Talks and consultant at Mother Hospital. I have worked with her in Amala for long years, and I know how much respect she gives to all the delivering females. I joined Amala immediately after my PG and senior residency, and as you all are aware, Calicut labor room is somewhere where I think at that time when it is so busy, we don't get time to think about these aspects. Okay, we are just thinking about delivering the babies and suturing and doing cesarean sections, but as a PG at that time, I never thought about this aspect of maternity care, giving a respectful maternity care. So after joining Amala, after working with Betsy Madam and Geeta Madam, it was really an eye-opener for me also, how to communicate with the patients and how to behave proper. When they are in pain, we are also really stressed, and it always happens like we might say something which might hurt them also. So I think that initial 1 year in Amala gave me a lot of insight to how to deliver a respectful maternity care. And I learned the lessons from Geeta Madam. So that's why when Joy sir asked me to give it, suggest somebody to give a talk on this, immediately I thought Geeta Madam would be the apt person. So Geeta Madam is going to tell you about respectful maternity care. Over to you, ma'am.
Thank you, Pramila. Actually, we have learned all this from the, I think the our guru, Dr. Paili. I think we have, sorry. Is the slide moving? My slide is not moving, right? Sorry, am I audible?
No, madam.
No,
You're audible, madam.
But how to change this one? Now I am in the middle of the
slide show nirthonu.
Escape escape adichittu.
Okay. Stop share.
Alla, stop sharing alla, madam.
Stop share venda.
Ayyo, stop share aayi.
Alla, stop adonnoodi share cheyyum. Allengi madam oru karyam cheyu, share cheyyunninte munne ആദ്യം അവിടെ പോയിട്ട് ആ പവർ പോയിന്റ് എടുത്തിട്ട് അതിന്റെ ഫസ്റ്റ് സ്ലൈഡ് ഇട്ടിട്ട് അത് മിനിമൈസ് ചെയ്ത് വെക്കും.
ഒരു മിനിറ്റ്, പവർ പോയിന്റിൽ പോയി അതില്
ഫസ്റ്റ് സ്ലൈഡ് എടുത്തിട്ട്
ഒരു മിനിറ്റ്, പവർ പോയിന്റിൽ പോയി. ഇല്ല, അതല്ലല്ലോ. ഫസ്റ്റ് സ്ലൈഡ് ഇട്ടു. ഓക്കെ, ഇനി
സ്ലൈഡ് ഷോയിലേക്ക് ഇടൂ മാഡം.
സ്ലൈഡ് ഷോ
മോളില്
വന്നോ? ഇല്ല.
ശരിയാവുണ്ട്. ഇപ്പൊ ചേഞ്ച് ആവുന്നുണ്ട് മാഡം. തുടക്കത്തിലത്തെ സ്ലൈഡിലേക്ക് പോയിക്കോളൂ.
ഓക്കെ, ഇപ്പൊ ശരിയായോ?
ശരി.
ഓക്കെ, sorry for that slight technical hitch. I'm not very good at this. I had asked my son to do it for me, so he is outside somewhere waiting for me to call. Anyway, good evening, respected seniors, dear colleagues, and my dear friends. So actually, safe motherhood, as I was saying, is something that is very close to our hearts. And April 11th is our Safe Motherhood Day. And so as part of observing the Safe Motherhood Day, I was asked to talk on a topic, and I thought this is something that not many people talk about. So I really feel this is something that I'm not saying that we are not respectful, But still, this is there are so many aspects of it that we are not very much aware about, or that we don't give so much of importance. So I hope at the end of this talk, at least if I can stimulate somebody to think about it, then my job is done. So the wisdom and compassion a woman can intuitively experience in childbirth can make her a source of healing and understanding for other women. For us obstetricians, the joy of giving a healthy baby to and making sure the mother is healthy and telling that happy news to the relatives, conveying that to the relatives and seeing their joy is something that has made me stay on in obstetrics. Actually, I never wanted to become an obstetrician, but after working in my first labor room posting, I realized that this is my calling. I wanted to be an obstetrician. So that is the most what is that, the satisfying part of obstetrics. But there is a certain other aspect. So we all know that there is something called maternal mortality, and we are aware of it. And every day, as per UN, around 830 women die. This might be a slightly old statistics, but still a lot of women do die during childbirth because of preventable causes. And what is needed is a lot of things like political will and commitment, strong health systems, then and all this improved access to quality care and efforts to reach it on to everybody. That should be there. So, and in short, our goal is no woman should die in pregnancy and childbirth. So as per the Sustainable Development Goals, the target 3.1 is to reduce maternal mortality. So we have been, the world bodies, including the WHO, the FIGO, FOXI, KFOC, TOX, everybody, and each one of us have been following all the strategies towards ending preventable maternal mortality. So our goal, our motto is zero tolerance to preventable maternal deaths. So, and India is on the verge of achieving this is a news which has come from the Ministry of Health. It was a tweet that India is on the verge of achieving the SDG target of maternal mortality ratio of 70 by 2030. And because as you can see in that graph, the mortality rates of India is coming down. And this is another plot which shows that the history of maternal mortality rate of India is coming down, and it has come down to 103 in 2019. But that is about the Indian statistics. And what about our state, Kerala? I'm so proud. We should be proud. We should all be proud in Kerala that we have been able to achieve the target of 2030 of the maternal mortality rate of 30 by 20, which was we were supposed to attain by 2020, by 2019. And how have we achieved that? This has been through the passionate and you could say the concerted efforts of all the obstetricians of Kerala under the eminent leadership of Paili sir and his team of the maternal of the confidential review through the confidential review of maternal deaths. So from 2004, the Kerala Federation of Obstetrics and Gynecology and the obstetricians, the eminent specialists, everybody has been part of the confidential review of maternal deaths. And the lessons learned through that has helped us to attain this goal of maternal mortality of 30 by 2019. But unfortunately, the last 2 years, the COVID has, of course, increased the maternal mortality, and the numbers were a little high. But hopefully now it has settled, and let's hope that this we'll be able to march forward and attain the goal of the MMR of 20 by 2030, even much before that. So this is one aspect, and we should all be proud that we have been attaining the numbers, the statistics, everything. But my topic for today is on something which is a little bit different from that. That is respectful maternity care. So what is this? So when I talked with my colleagues in my department, as well as with the colleagues outside the department, they were asking me, of course, we always give respect to patients. What is so special about this term respectful maternity care? I can say it in one word. It's almost like a patient-centered care. It's it focuses on the interpersonal aspects of maternity care. So WHO explains it as that is a care organized for and provided to all women in a manner that maintains their dignity, their privacy, confidentiality, and it ensures that they are free from harm and mistreatment. It enables the mother to have informed choices, and most important of all, it provides continuous support during labor and childbirth. So if we think of all the aspects which come in that, it focuses on the interpersonal aspects of maternity care. So just think, how much do we give importance to that in our practice? That's just what I want everyone to think about. So the background was, we have been always saying that to reduce the maternal mortality, women have to give birth in health facilities. So that they get timely access to skilled care, and they can be referred in case additional care need for additional care arises. So of course the facility-based birth has increased, but we find that in spite of this increase in the increased proportion of women giving birth in health facilities, there is not a corresponding, or there is the expected reduction of maternal and newborn mortality and morbidity because of this facility-based care. That has not occurred. So childbirth, that experience during that period, the women are the most vulnerable. And unfortunately, if we go through the literature, we find that whether it is a rich country, poor country, low income, middle income, anything, mistreatment of women during childbirth is widely prevalent globally. So only thing is, in the low income and the high income, what do the women perceive as disrespect and abuse? That may be slightly different. So in the low income, such meaning their expectation may be slightly like they want a clean environment, they want some privacy. Such things are more, they may give more importance to that, and lack of that they may consider as a disrespect. But in a higher income or a higher educated people, they may say that I want to be part of the decision, whether I deliver vaginally, I have a section, I have an episiotomy, I have an induction. So that may be the aspect that they consider. If they are not given that, they may consider as disrespect or abuse. So anyway, the mistreatment of women is prevalent. So, and we all agree that all women deserve respectful maternity care. Mistreatment may be there in other aspects of care. Any time of the care may be there, but this is the time when they are the most vulnerable. They are depending on us. They have come to a facility to get to feel safe, to feel respected. And if she is not given, it does not feel that, she is not going to come back to you for antenatal care appointments, or even she may not even present in labor. And what is the end result? It increases the risk of death and disability for both her and the baby. So this is one aspect that, of course, as healthcare workers and the health providers, we never, ever, ever think that, okay, we are going to go to the hospital and be disrespectful. Nothing like that. But the perceptions of the patient as to what constitutes disrespect or what constitutes abuse are also important. So it's not only the clinical care that is important. You are skilled in your specialty, you are going to give skill care, but at the same time, is the patient experiencing the same happiness or the same safety or the same respect? So that aspect is also very, very important. So this was a article which was published in Lancet by Boren et al. As late as 2019, and they have done the studies in the low-income settings of Guinea, Myanmar, Nigeria, etc. And they have conducted a study as to how women were treated during facility-based childbirth. And that study, the interpretation was that more than a third of the women experienced mistreatment and were particularly vulnerable around the time of birth. So, especially when they were younger, they were less educated, they were more likely to have a feeling that they were being mistreated and abused. So, that was the article which came out in Lancet. So, and these are some of the things that are noticed. That is, 4 in 10 women may be experiencing physical or verbal abuse or stigma and or discrimination. 15 minutes around the time of delivery is the time when they probably have the maximum feeling of being physically or verbally abused. We can just reflect on how that can be, because very often we want the patient to deliver fast, and so that may be the reason, but still this may be considered as a form of disrespect or abuse by the laboring patient. She is at her most vulnerable. So again, neglect during childbirth. Some of the patients were not where the deliveries were conducted without a proper provider, and some were not given pain relief during labor. So the category is when the aspect of when the concept of respectful maternity care came, these were the 7 aspects which were considered as the categories of disrespect and abuse. So it could be a physical abuse, it could be a non-dignified care. I'll come to that, some examples later. It could be a non-consented care, it could be a non-confidential care, or it could be discrimination, abandonment or withholding of care, or detention facility. So these are the 7 aspects they have meaning categorized. So for example, physical abuse could be that it could be as bad as slapping, pinching, etc. Even they say a forceful fundal pressure could be considered as a physical abuse. And of course, definitely, if you stitch an episiotomy without anesthesia, then it could be very well considered as a physical abuse. And a non-dignified care could be the use of harsh words to the patient that may suggest rudeness or reprimanding. She may ask you for help or she may say that she wants to, meaning like she needs some pain relief, something. So if you tell her, okay, I have something else to do and I can't look after you or something like that, that may be considered as a non-dignified approach to the maternity care. And non-confidential, of course, the confidentiality of the patient while taking history, while examining her, or even delivering her, all this is very, very important, because we should ensure that they have enough privacy and confidentiality. And discrimination, when you deny the services due to lack of money or because she's of a ethnic origin. Probably that is not very much prevalent probably in our state, but still it can happen. So abandonment and neglect. So even when you have enough facilities, infrastructure, staff, all those things, if you don't provide the services, then that is an abandonment or neglect of the care. And detention, sometimes, very rarely, the patient may be detained in the facilities because they are unable to pay. But another aspect of it, when the baby is in the nursery and she's there in the facility, if we don't attend to her, that also is considered as a detention. So these are some of the, as I said, these are the 7 aspects of abuse or disrespect that they have categorized. But why am I talking so much about respectful care? We have said already that disrespectful care negatively impacts on childbirth experience. These are some of the articles, or these are some of the evidence that came, and it deters the women from attending the facilities. We are telling them, please do deliver in facilities. And if we don't give them a positive childbirth experience, that they may not return to your facility. Increase in, and what is the ultimate effect? It may increase the near miss and mortalities. We want to give them a safe motherhood. We want to make them safe. We want to reduce the maternal mortality and near miss. And here we are, and increasing the and this, if we can cause increase in maternal near miss and mortalities, and with the wider implications on the societies, facility costs, and local communities. So that this is one thing. See, the provision of respectful care may not be prioritized in the same way as the provision of clinical care. That we are aware. Actually, we are aware. We are giving a lot of clinical care to the patient, but it's also important that we should give the respectful care. So the WHO framework for improving the quality of care for women during childbirth highlights that women's experience of care are as important as clinical care provision. So this is what they say. When you have a quality, how do you assess the quality of care? Of course, there is the provision of care, which includes the evidence-based practices for routine care, management of complication. Then there should be actionable information system, functional referral systems, all those things. At the same time, the experience of the patient is also important. That is effective communication. The patient should be treated with respect and dignity, and they should get emotional support, pain relief. All those are important. And this, together with competent and motivated human resources and the presence of essential physical resources, that is where we have the optimal outcome, and you have the optimal we reach the optimal goal of safe motherhood. So this is that in another form. So essential physical resources should be there. Competent and motivated staff should also be there. And the very, very important emotional support from a companion of choice, effective communication by staff, pain relief strategies should be in place. And of course, there should be regular labor monitoring, documentation, feedback, and audit. And one more aspect which is stressed is oral fluid and food intake. That also has to be taken care of. Then another thing is the mobility in labor. Once the patient is in labor, she should not be confined to her bed. She should be allowed to move about. And one more aspect, birth position of choice. It's not essential that she should. We should decide how she is going to deliver. She herself can decide her position in second stage of labor, or even in the first stage when she wants to walk around, she wants to have support, then we should be able to provide this. And there should be a pre-established referral plan, continuity of care, and all this is what constitutes respectful labor and birth care. So that is what the WHO intrapartum guidelines of 2018 stresses. So that is at least we should think of 5 things. That is respect and dignity, a companion of choice, clear communication by the maternity staff. There should be pain relief strategies, and mobility in labor and birth position of choice. So they have brought about new labor and birth guidelines, and the whole world body actually in 2011, because we have the human rights declaration and all that, and in 2011 there was a White Ribbon Alliance which brought about the concept of respectful maternity care, which has been taken up by all the world bodies. And we have been talking about respectful maternity care, but still the whole it has not brought about that much of change. So let's take one aspect of this, what the respectful maternity care is all about: companion of choice. It may sound, meaning all these aspects may sound a bit meaning like a vague or like that, but when we come to companion of choice, what is the role of the companion? She or he is going to be the advocate for the mother. You can, if you have conducted deliveries or you have attended deliveries where the mother or the husband or somebody is there with them, then you understand the difference. There is a lot of difference, and the mother is that the person with the mother, the companion is going to be the advocate for the mother. They are going to allay the anxiety. This is somebody who is familiar to me. They are going to be with me. So she doesn't feel alienated. She is in a comfortable situation, and that provides the reassurance that, okay, everything is going to be okay. And on besides that, they are going to ensure that she is well hydrated, she has enough nutrition. And you have seen that how massages and talking or music, all those things, and by the companion is going to provide pain relief. And even if that is not adequate, they can request the medical personnel for pain relief. They can request the medical personnel to have a look at the patient and reassess her if they feel the need, and give information on progress. If that person is there, then they will act as a liaison between the mother, that is the mother in labor, and the relatives. Actually, many of us feel that the companion is an obstacle. No. If they see that we are providing the care that they require, if we are treating them in the way they should be, then they are going to be our advocates. They are going to say, this doctor, this nurse, this person has looked after her so well, but in spite of that, okay, something happened, but that is okay, because they are not going to, they'll understand. So, but one thing that in our setup is required is that very often the companion of choice, what is important is that in our setup, they should be counseled, they should be educated as to what to expect, and they should not be meaning they should not collapse. Meaning there are people like that. So they should be the ideal companion. They should be the be able to support the patient. So antenatal classes where the mothers, the husbands attend, that may help you to create some companions of that passion. Okay, so so I have told all these things. Is this something that I have cooked up? No. Cochrane 2017 evidence says when there is a companion in labor, that will improve the outcome of the mothers and babies. There is increased spontaneous vaginal birth. There is reduced cesarean section, instrumental delivery, everything comes down. The duration of labor is reduced. She has lesser pain relief requirements, and babies have better Apgars, or there are less babies with low Apgars. And overall, if you check, they have decreased negative feelings about childbirth experience. In short, they find that is a more positive childbirth experience. And if you think of the other part, there is no evidence of harm for continuous labor support. And especially we feel, okay, in low income setup, it's very difficult to have companions. But India, I think India is slowly, and Kerala, various parts of Kerala, we are proving that in low income settings, even with less staff, companions are going to be helpful in our practice, and they help to reduce the cesarean section rates. So it's not like this is not possible. It should be possible, and it will help us in the providing better care. So the other benefits for having a companion are that it improves the maternal-infant bonding, to have somebody to support her in the initial part of breastfeeding and care of the baby, improves self-esteem. She feels more confident, reduces postpartum depression, and overall, again, a more positive childbirth experience. So that is only one aspect. So can think about the other aspects, and I think the whole picture together is going to give help us a lot. So there are 12 core principles of RMC. That is the respectful maternity care, being free from harm and mistreatment, maintaining privacy and confidentiality, preserving the women's dignity, prospective provision of information. We should tell the patient what to expect, and if possible, there are a lot of people who say, okay, doctor, you decide, but still, we should seek informed consent wherever possible, ensuring that the patient is not separated from the family unit, access to the family and community support, enhancing the quality of physical environment and resources. That is one thing. There was a study conducted in the northern part of India, where the main thing that they were feeling was that they don't have a clean environment, and often they had to have a congested situation. So these are some things which we can improve, and providing, make sure that everybody has equal, are treated equally, engaging with effective communication. Communication, of course, is the key to avoiding a lot of problems, and respecting women's choices. That strengthens their capabilities to give birth. Suppose she wants to walk around, she wants to have her give birth in a squatting position. For us, it is difficult to accept for some of these, but if wherever possible, they should be given that option. Availability of competent and motivated human resources, and that motivation is very important, because to change from the older concepts and accept the newer concepts, and to get motivated, that is to change, that is to accept what the woman wants, is also important. So provision of effective and efficient care, and make sure that there is a continuity of care. So these are the 12 principles. So what do women want during childbirth? That a systematic review was done by Down et al. If you go through this, it will seems like heaven. So they want a positive childbirth experience that fulfills or exceeds their prior personal and socio-cultural beliefs and expectations. They have some expectations on what they are going to face, but that should be this one should be better than that, and that includes giving birth to a healthy baby, of course, in a clinically and psychologically safe environment. Sure, with continuity of practical and emotional support from birth companion. So they want a birth companion who will give practical and emotional support. And at the same time, not only the birth companion, so the environment should be good psychologically, clinically. The companion should be supporting practical emotional support. And the third aspect is the kind, sensitive clinical staff who is going to provide reassurance and technical competency. So all these is what the women want. Of course, this is something which is achievable, but some parts of it we don't give as much care. The last part, definitely, we are giving technical, we are getting technically competent, we are giving, we are being better in management of so many things. But the reassurance part, the birth companion, the environment, all these are important. So I just want to, because we to meet with this dream of the what the women want during childbirth, for a positive childbirth experience, we have been trying. So this I think most of us know as the partograph, which is what we use for monitoring the progress of labor. Of course, it's very important to know about the partograph. But this, if you go through that, this is just a recording of fetal heart. Then you have got the dilatation, you have got the BP, pulse, everything, contractions, everything. Where is the place in this chart for the respectful maternity care or supportive care for the patient? It's not there. So the WHO has changed our partogram to another type of partogram. It's a futuristic type of partogram. And the important one of the important differences in that, I've not shown the whole WHO labor care guide. There are a lot of differences in that, but I have stressed on this because this is my topic. So in that partogram, or the WHO labor care guide, as it is called now, which the WHO has brought out last year, the first part, which is the patient's information, that the initial parts of it, then comes the supportive care. See, if you can appreciate that, the very first thing they have mentioned is the companion. Then you got the pain relief, you got the oral fluid and the posture. And every half an hour to 1 hour, you have to assess whether the patient has a companion. If not, okay, you are going to bring in a companion. Is the patient having pain relief? Okay, so these things also matter. Even in the second stage, the same thing is continuing in that labor care guide. So WHO and the world bodies, clinicians are attempting to bring in the aspect of respectful maternity care into our safe motherhood initiatives. So generally, we have to achieve that. We have, or promote that. We have to have a national policy. We have to have a healthcare facility for a health facility level policy and a community. All these together can only bring out a change that will promote dignified and respectful maternity care. So in India, the government has brought out the Lakshya program. That is for transforming health, the care of the pregnant mother and the childbirth experience. They have changed the labor room facilities. They have enhanced the facilities. And one of the aspects that they are stressing is on respectful maternity care. So this is on the public delivery points. And the FOXI, that is our Federation of Obstetrics and Gynecological Societies of India, has brought out something which is called Manyata, which stresses on the transforming the maternity care in the private maternity homes as well. So this is about the what we have tried to do in our country. So it's time now for us to change also. So as a take-home message, I would say that childbirth is a period when the woman is extremely vulnerable. If you look at the face, they are so they are so very dependent on us at that point to give them what a positive experience. They really deserve a positive childbirth experience. And reviewed, we have been saying that why the patients don't get adequate care is probably because of geographic, financial obstacles. They don't come to the facilities. But reviewed studies suggest that fear of disrespect and abuse maybe sometimes a more powerful deterrent to use skilled birth care than geographic and financial. So where do we stand there? So there are certain non-clinical intrapartum care practices such as emotional support through labor companionship, then effective communication, respectful care, which are often not prioritized, and they are extremely inexpensive to implement, and they should complement any necessary clinical intervention to optimize the quality of care for women and their families. So this is all what I have to say on respectful maternity care. I hope I have at least put a thought into everybody's mind that it is possible for us to improve still, because we need to make the mother and the baby healthy and happy. So This is a mother and a child who has had a positive childbirth experience. And as Mahatma Gandhi said, be the change that you want to see in the world. So thank you so much for your patience.
Thank you, madam. Now it is discussion time. Is there anything?
Stop sharing. Okay. Thank you, Geeta madam, for that excellent talk. This is even though we all know giving respectful maternity care is important, but this is something which includes so many aspects, and thank you for bringing out those aspects. Anybody would like to add any experiences from their side?
Dr. Padmam was saying how to give respectful care in a very busy medical college setup. I think putting those curtains, the way you showed that photograph, no? Putting those curtains there and having a birth companion should not be impossible even in medical colleges. What do you say, Rashmi?
Yes, madam, exactly. Giving
You have got a
privacy
very
and
high-tech 5-star medical college, no, now?
No, madam, actually, we are struggling to improve. But actually, what you said is very true, because putting on curtains itself will have improved the perception, because they have that itself have given the confidentiality and privacy to the patient. So actually giving the respect to the mother starts from the confidentiality and the privacy issue. Earlier, it was actually every laboring patient would be laying down. I mean, everyone will be seeing. So that was actually, that's not very acceptable. Now that
Can I just
changed.
be little partial and little, it sounds obnoxious, but I see that when I come to practice in Kerala, I find that examinations are done without putting a bed sheet. No. You just put a bed sheet on cover the thighs of the patient before examining.
Yes, madam.
I find that the sisters, I have worked in so many hospitals in Kerala, they just pull the whole petticoat up, and the whole thing is exposed. And next, if it is a heavy, busy hospital, I find that this thigh is exposed in 2-3 people and everybody is watching it. Imagine having to lie like that. What is wrong in putting a cloth on there? How much ever I say, and in between, if I come and they think I'm not watching, they're doing the same thing. Like, it's being taught in the medical colleges is what I feel. I don't know. What do you think, Rashmi?
No.
Or Ramila or Geeta.
No, madam. Actually, can I answer that question?
Certainly, yes.
The problem is that, as Padma madam has said, in busy centers, what is important is giving care to the patient. So we are concentrating on clinical care, and we are not meaning probably the things have changed now, and the importance of communication, importance of giving respect to the patient are coming up. So previously, when we were studying, of course, Calicut was so busy. We were continuously working, and that aspect never went into our head. But after working in different places, especially in the Middle East, I have come to realize that they won't allow you to do that. And even in the theater,
even in Bombay, we had a very busy labor ward, but no patient would be examined without covering her.
Yeah,
don't tell me Kama Hospital was a very busy hospital.
Yes,
but we used to do this covering, and when I come here, I find that it's lacking somehow.
Yes, madam, that is exactly why I chose this topic, because there are very small things. I wanted somebody to come up with all these, because these are very small things. Just covering the patient, just talking softly to the patient, communicating with them. And even in the theater, if you are draping the patient, remove their clothes only after, you can keep it till you put the drapes. There is no harm in that. Very often I see them being stripped cleanly, and that is very bad, because that the patient totally loses confidence. So it is very, very important. So I wanted to bring that out. But as I have put in the last slide, we have to change. We have to bring the
medical colleges have to teach that.
No, not only medical college, madam. Every place Everyone. Yeah.
Yes.
Medical college, as Rashmi said, they have their small um, obstacles, but once they are doing that, the others will follow their example. That I think they are coming up with the ways and means of doing that. So this curtains and other things, there are places where there are curtains, but that is not used. That also I know.
Yeah,
So,
that's also there.
so that is what is important. Importance is that
The hooks are lost.
just imagine us in the position. I know it is a very wrong way of saying things, but still, so we should give the patient what we want from the other people. So I think that is important. Respectful maternity care from that aspect is very, very important. Every small look, word, everything is important. And I think previously for IMOCALs, we used to have a class on labor management, which used to start with how do you greet the patient? And that used to start with please welcome the patient with a smile. So that itself is very important. So we used to have that. So I think with the clinical technicalities and everything, we have forgotten all those, but I think it's time we brought it all back. And it's very important because the current generation and the coming generations are going to expect us to treat them differently, not like the people who used to come to us.
Dr. Padmam, would you like to put on your video and contribute? You are there in front of the screen. I think she's left.
She's there.
No. The iPhone person who said that there is, she saw 2 cases of VDRL and they have given, who is the iPhone person? I don't know, but that's very valuable information. When you sit pulled up with so many gynecologists, then only you get those cases out. But still, even that one case, if it is there, it's worth giving testing for VDRL, I suppose, no?
Yes, madam. Actually, we also had some few 2 or 3 cases of VDRL positive recently, last few years.
Okay.
Because, from my PG days till then, we hadn't seen any VDRL positive cases, but last 3 years we had some cases, not very, but 2 or 3 or 4 cases we had.
And what about birthing companions, like what Geeta said? Is it possible in medical colleges?
We had, madam. We were having birth companions. Actually, before COVID, in 2019, we had, because of for this Lakshya, one of the cycle is to include birth companion as a part of respectful maternity care. So we had introduced. Actually, even though there were some apprehensions, it turned out very fine, because usually it is the mother or the female companion, some sister or
mothers
someone.
are never good, because the mothers sometimes fall down. I had once a patient for whom I had to try a lot, too much time to get the normal delivery. His mother swooned and she had to be admitted to the casualty.
That is where the antenatal classes help. Actually, we have antenatal classes where we...
whatever it is, mothers are notorious.
Yeah, but still, no, madam, once we have explained to them and we take them to the labor room and introduce them to the staff and show them the thing, then I think that will change.
Why I am telling you, antenatal class I give, and every time they come, I say, look, you will get lactation only on the 3rd day. The baby has to suck. You have to drink 2 liters of water. Whatever you do, next day after delivery, doctor, give me medicine. This is common. Whatever antenatal class you give them, they just don't listen to you. They have their own science.
This is a fast food era, madam. They want things to happen fast.
Fast, yeah. I said, like, the baby's head is out and the milk should flow out. Don't you have you not spaced this, Pramila?
Yes, madam. Definitely.
We all give medicines.
We all face this. And but that is there. But still, I think still it's worth the trouble.
Maybe we do our duty. That's all. Half the time they're not listening. How much you tell them also, the same thing will happen. When you enter after delivery, they will say, give me medicine. Doctor, Paliya. What is happening? I don't know.
That happens daily with all of us.
Yeah. It is there. Yeah. You can take over Sharmila and Pramila.
Lola madam, you wanted to say something?
No, I was telling this Galilea business is there with all of us. Cannot be helped. I think we have to. I think it is something like after we explain all the problems like that, I think we have to take it in our stride. എല്ലാം കേട്ടിട്ട് കുഴപ്പമൊന്നുമില്ലല്ലോ വേറെ കുഴപ്പമൊന്നുമില്ലല്ലോ ചോദിക്കും അത്രേ ഉള്ളൂ. We have to take it in our stride. പാലില്ല എന്നുള്ളത്.
Paalilia is a common thing.
Madam, actually, coming back to the birth companion, actually, when we introduced it, although we were apprehensive, we found that we had a very good response because we didn't have that much of resistance from patients or bystanders, and they
are very
actually
happy, very happy.
they are
Only
very
problem
happy
is,
and comfortable. And
no, the only problem in our hospital was when we were allowing birth companions, it became a socializing event. Doctor, ഞങ്ങൾ ഇത്രയും ദൂരത്ത് നിന്ന് വന്നതാണ്, ഞങ്ങളൊന്ന് അകത്ത് പോയിട്ട് കാണട്ടെ. I said, bloody, she's laboring. This is not the time for you to socialize, and then that makes it irritating. They get irritated. So now we have got a solution for that also. I provide a gown for them to wear.
That's what we do. We
gown and mask and everything, and make it look as though it's a very sterile area, so that then other people can't come in. So that we have to find solutions for everything.
That's exactly what we do, madam. We ask them to put on that white shirt.
Labor room. They think it's a general ward. I said, this is nonsense. Is there?
Geeta madam, it was an excellent talk. It was really nice. You brought out so many points.
Yes. Okay. Yeah, Rashmi.
It was such a wonderful talk. You brought out so many points and evidence base also. So many, studies supporting it, and it was really nice.
How much time she has spent on all
that? She must have spent a lot of time.
Thank you. No, actually, we do have a meaning like a separate setup for companions. We still, in spite of all this, we have not started so much of companionship in the labor, but still we do have a facility for that. So, and I have found that is so much of reward, that is so rewarding for us, the joy on the face of the people who stand with the patient. And the patient is and the laboring mother is so relaxed and so comfortable. It's really worth it. But of course,
the companion should not be having a mobile phone.
Yeah,
no, we don't allow mobile phones. Mobile phones are not allowed inside the labor room.
That is very
a government order.
Girls, when they enter, companion comes in, they want to take a call on mobile phone to relatives in the Gulf. Come on now, this is the limit. So mobile phones out. That is.
But those are small things that we can always make sure. That's all, madam. But the main point of it is that a companion is going to improve the outcome of the labor, definitely.
I'm just telling
our life more comfortable.
And giving the choice of position during labor, because allowing them to sit. Because earlier when we were doing PG, നമ്മൾ കിടക്കാൻ തന്നെ നിർബന്ധിക്കും, കിടക്കൂ അവിടെ കിടക്കൂ എന്നാണ് പറയുന്നത്. പക്ഷെ ഇപ്പൊ നമ്മള് ഇരുന്നോളൂ, ഇരിക്കണമെങ്കിൽ ഇരുന്നോളൂ, നടന്നോളൂ. And we
have they all like to lie down above them. We have to force them.
No, madam. I think
some of them
many of them want to get up and stand. They want to lean forward. They want to walk. There are a lot of people who ask for this.
We don't force, but I'm just telling you that
no, that is this is because very often we put an IV line and then we force them to lie down. So that is not needed. You can give oral fluids, you can give and oxytocin only when needed. That's all.
Yeah, that is the thing.
I'm not going to the extreme of a midwifery based practice or anything like that, but in our own practice, in the facility-based childbirths, we can do a lot of things that can improve their childbirth experience. That's all.
Okay. This has been very fruitful discussion. And thank you so much, madam. And thank you all the doctors who have contributed to this fruitful discussion. Can we move on now to the vote of thanks? Okay. I think Dr. Rashmi left. Is Dr. Rashmi here?
I think she's left.
Okay. So can Dr. Pramila Menon, Dr. Pramila take over the responsibility of vote of thanks? Okay.
I think Arishma madam lost her connection, that's why. Anyway, in her absence, let me do the vote of thanks. First of all, let me thank the Women's Wing of IMA and Shobna madam and Dr. Sharmila for madam ആ ഗ്രൂപ്പിലേക്ക് കൂട്ടി ഒരു മിനിറ്റ് അത് കഴിഞ്ഞിട്ട് പുറത്തും കൂട്ടാം. So thank you for organizing this event in association with Safe Motherhood Day. And let me also thank the speaker of the day, Dr. Geeta. And as you all know, she has done real justice to the topic, and she has brought out a lot of important points regarding the respectful maternity care. Thank you, Geeta madam, for that enlightening talk. And thank you everyone who has joined this session and made this discussion lively. Thank you, Dr. Sharmila, once again.
Thank you, Dr. Pamela. ഗീത മാഡത്തിനെ ഞാൻ പേഷ്യന്റിനെ അയക്കാണ്, പക്ഷെ മാഡത്തിനെ ആദ്യമായിട്ടാ ഞാൻ കാണുന്നത്. പണ്ട് കണ്ടിട്ടുണ്ട് അല്ലേ? ശരിയാ ഒരിക്കൽ കണ്ടിട്ടുണ്ട്. ശരി, പെട്ടെന്ന് ഓർത്തില്ല. അപ്പോ ഓക്കെ, താങ്ക് യു ഓൾ.
അപ്പൊ താങ്ക് യു ആൻഡ് Shobana madam.
Thank you. Good night.
Okay, good night everybody. Have a great day.
Good night everyone. Okay, bye. Thank you.